Thank you very much. It is an honor to be presenting in the esteemed course. So it is a neurointervention is a broad topic, but I will be just uh, summarizing some of the basic techniques and its applications in neuroradiology. So neurointerventions deal with treatment of multiple conditions like subarachnoid hemorrhage. One of the most causes is the aneurysmal bleed. It also deals with the treatment of AVMs leading to intracerebral hemorrhage. One of the major component of neurointervention is treatment of transient ischemic attacks like which are mainly caused by carotid artery stenosis and also by vertebral artery stenosis. And a very major topic of neurointervention is mechanical thrombectomy. So it is basically a combination of diagnosis, the interventional management, and the neurocritical care, which makes the things go. So we have evolved recently in 10 to 15 years. We started from a single plane angiography machine. We moved to biplanar angiography machine. So the biplanar angiography machine is critical for neurointerventional procedures. Apart from that, the 3D reconstructions and the VASO-CT or the Dyna-CT, the integrated CT scan, which is available with the angiography machine, is critical, and also the 3D reconstruction to know about in case of mechanical thrombectomy if there is post-operative hemorrhage after mechanical thrombectomy, even while doing coiling, it is necessary, or placing a stent in the main vessel, it is necessary to determine the exact diameter and the length of the vessel, and we can monitor our stent size according to it. So to know about the devices of neurointervention procedures, it is very important that we are familiar with the devices. Initially, we place a long sheath. We can use a transradial route, which is used these days very frequently. But in the conventional route is the femoral route. We place a 90 centimeters long sheath. We use a guiding catheter through it. And then we use small micro catheters and micro coils to deploy the coils and deploy the stents. So the neuroradiological imaging understanding is very critical for any intervention. Either we are dealing with CT perfusion or we are dealing with mechanical thrombectomy, because diffusion perfusion mismatch is critical if you are doing mechanical thrombectomy. This means that if we are doing mechanical thrombectomy, the patient has landed within 6 hours, we do an MRI and there is hyperintense signal on DW, but there is normal signal on FLAIR images. So this is viable brain and we can save it. So initially we're starting with the aneurysms, subarachnoid hemorrhage, leading to subarachnoid hemorrhage, most common at the ages of 40 to 50 years. And with proper endovascular treatment, where the patients can lead an independent and productive life. Initially, clipping was used, and still clipping is a major treatment of cerebral aneurysms. Considering endovascular and interventions, it has evolved greatly regarding the coiling of aneurysms. And again, there are multiple techniques. I will be just touching the brief introduction for the techniques. And pre-operative drugs play an important role, leading to prevention of thrombosis of the main vessel. And also there is while doing in neuroendovascular interventions, vasospasm is a major factor, and we have to again be very cautious doing cerebral interventions with vasospasm. So if we have a wide neck aneurysm is that aneurysm whose neck is more than 4 millimeter. So we cannot do just simple coiling in such aneurysms because the coil will prolapse into the main vessel. So we have to use additional techniques for the deployment of coils, and these devices have now become available. So one of these devices is balloon assisted coiling. So what we do, we place a balloon in the main vessel, This is a microcatheter with a pre-placed with balloon. We inflate the balloon, and after inflating the balloon, a second microcatheter can be passed, or a microcatheter can be initially passed, and this microcatheter can be, and the balloon can be passed into the other vessel. We can inflate this vessel, and we can safely put coils in it. In another case, in the large cavernous supraclinoid portion of IC aneurysm, again, a balloon-assisted coiling has been done in this case. A blister aneurysm, again, balloon-assisted coiling. So there is also a technique which is known as the double balloon technique. So if we are doing, this is mostly used in MCA coiling, aneurysms of coiling. So we place two balloons, one in the superior division and one in the inferior division. We can inflate both balloons and we can deploy safely the coils. With these microcatheters like Scepter C, we can also deploy stents. So there are multiple stents. We can also do simple stent assisted coiling. We can place a stent like Elvis, and we through another microcatheter we can pass through the studs of the stent, and within the aneurysm lumen we can place coils. And in this way, the coils are adequately placed within the sac of the aneurysm without any prolapse. So another case of supraclinoid aneurysm, it again, this is the role of 3D reconstructions is very important, because we have to know about the proximal and distal diameter of the vessels, so that the stent or the coil does not prolapse into the main vessel. So we can also do treatment of blister and dissecting aneurysms, and we can place flow diverter stents. The flow diverter stents are actually special stents which have extra metal coverage. It is basically used to change the hemodynamics of the vessel, and when we place such stents in the main vessel, there is thrombosis of the vascular aneurysmal lumen, which is spontaneous with passage of time. So this was an aneurysm which was initially treated with coiling, but after 6 months, when 3D reconstruction was done, there is the patent neck still available. So in such aneurysm, we place flow diverters. These are costly devices, but these are very helpful. In this case, a pipeline flow diverter was used. So there are multiple different trials considering regarding clipping and coiling. The famous ISAT trial and the barrow rupture trial. The ISAT trial showed that the relative risk of aneurysmal coiling is less, approximately 22.6%. We can also deal with the treatment of stenosis at the origin of the internal carotid artery, leading to due to atheromatous plaques leading to TIAs and stroke. So carotid endarterectomy and both carotid endarterectomy and carotid artery stenting are effective management tools. In regarding stent placement, we can place a stent without any protection device, or we can place a filter or a proximal balloon. Still, the trials show that even the results are similar with and without protection devices. Another case of carotid artery stenting. So these are the different trials which showed that Sapphire trial and the SPACE trial. These regarding carotid stenting trials, there is risk. These trials have showed that there is reduced risk in morbidity, in mortality, especially with carotid artery stenting, but there is higher risk of MI with carotid artery stenting. So these, it is not the procedure, but I think the expertise matters most, and the patient's condition is more, and it's his comorbidities are more important when we decide regarding a neuroendovascular treatment. We can also do stenting of intracranial atherosclerosis in this case, like basilar artery, there's focal atheromatous plaque, and we can place stentings In Sampras trial, it is shown that when we are doing acute mechanical thrombectomies, we initially do not place stent at the same time when we are doing mechanical thrombectomy. We try to avoid it, and we try to do it after 24 to 48 hours, because these trials have shown that when we do place stent at the time of mechanical thrombectomy, it has poor prognosis. So the major component is mechanical thrombectomy, and these days it is also getting I can think prominence in the media also. Recently, TPA has been made available in the government hospitals. TPA is administered by neurologists with so the time limit is 4.5 hours in which TPA is usually admitted to. But it has been shown in regarding neuroendovascular that the TPA role of TPA is limited in major vessel occlusions like M1 branches and A1 branches, and its also role is limited in posterior circulation. But it is definitely a very good tool, and TPA in combination with mechanical thrombectomy leads to very good results. So again, we have to make the people aware that if this regarding the symptoms of stroke, because if such time is brain, if such a neurological incident happens, we should immediately transfer the patient to nearby hospital so that immediately management starts. In France, while I was doing training I was very honored to do training with Professor Jacques Moret. He's a legend on neurointervention. Even in villages with air ambulance, the patient was shifted to our main hospital. When the patient was being shifted from air ambulance, the EMS team called the consultant on call. He immediately informed me. By the time the patient landed on the table, the mechanical thrombectomy table was already ready. The consultant was ready. The neurologist was on the table doing examination. The TPA was administered simultaneously, and we did mechanical thrombectomy. Before the CT angio and the MRI was performed in our hospital or in their hospital of the locality of the patient. So Dawn trial, the famous Dawn trial has shown that mechanical thrombectomy has excellent results in the treatment of stroke. So there are different devices. There are stent retrievers, there are aspiration catheters like Sophia Plus. Again, we place a 6-French sheath. We could use a navigation catheter. We can use a large navigation catheter like Sophia Plus. We can deploy a simple stent, non-retrievable, and retrieve the clot, or we can do simply place a catheter and we can do suction to retrieve the clot. So some of the cases done by me at France and in Pakistan, this was a old patient. He had an coronary angioplasty initially, and he was then admitted for surgery of aortic stenosis, and his double antiplatelets were stopped in the hospital and prior to surgery, and the patient developed acute onset right-sided weakness with aphasia. So when my protocol initially in Pakistan, in France was we did DW MRI with MRA, but in Pakistan I usually do that. It varies from hospital to hospital. We do CT brain non-contrast with CT angio, and because it saves time, and because CT perfusion is not available in Pakistan in most of the centers, I rely on the MRI. So with this, I also rely on the MRI, DW, ADC, and FLAIR images and T1 images. So with CT non-contrast, I rule out brain hemorrhage. With CT angio, I know about the site of the occlusion, and with MRI, I see how much the salvageable brain is available. So if we see in this case, if you just compare right and left side, there appears to be occlusion of the M2 branch of the left MCA. There is paucity of branches. So I did a conventional cerebral angiography. Again, there is no adequate revascularization. I used a destination sheath, and then I passed a stent retriever. In this case, this was a solitaire, and the clot was retrieved, and this was the clot. So the procedure time was approximately 28 minutes, and patient, alhamdulillah, made complete neurological recovery. Next day, post-procedure CT showed no hemorrhage. Another case, the 41 years old male, he was lost while seen at 10:30 p.m. He slept, and while sleeping, he developed left-sided weakness with facial palsy. The NHS stroke scale was 14. He presented to emergency in the morning at 5:08 a.m. Approximately 6.5 hours. So when we did CT and CT angio, there is hypodensity in the right parietal lobe, which may be due to prior ischemic insult. But when we did compare the CT angio results with the CT brain results, there is appears to be occlusion at the origin of left ICA, right ICA, with non-opacification of right MCA. So there, in such cases, we usually mention it as T occlusion. So because there was also CT perfusion mismatch in this case. So we did mechanical thrombectomy, we passed, and we used a microcatheter. Apart from that, I also used a Sophia Plus, and alhamdulillah, this was the prior, and this was after the revascularization. So there's disruption of blood-brain barrier, mild, but the patient made gradual recovery, and 30 days he was improved in follow-up. Another case of left MCA, again, this was mechanical thrombectomy was done with stent retriever. So another component is cerebral AVMs leading to bleeding and seizures. And there are different techniques, embolization, stereotactic radiosurgery, and neurosurgery, which lead to good results. We use different techniques like fill and embolic agents like glue when needed. So this was a case which I performed at Mayo Hospital under supervision of Professor Dr. Majbi Masood. This was a young female who had an ear AVM. So when I did a conventional cerebral angiography, this showed that nidus of AVM, and also there is a pseudoaneurysm present within the sac. So again, the imaging appearance is and the knowledge of the vascular anomaly is very important for the treatment. So in this case, I used fill with PVA particles. So the picture was released with after permission of the patient. So alhamdulillah, there was excellent stasis and no vascularity. So before this was, then the plastic surgery team decided to operate on the patient, and this was the lesion. And this shows adequate necrosis within the AVM. Another case of AVM, high flow AVM, which was treated with fill. Another case of AVM leading to hemorrhage, and this was treated with the fill. So in short, it is combination of different modalities, neurologists, neurointerventionists, diagnostic neuroradiologists, neurosurgeons, neurocritical care, and rehab, which make the things go. And I think we can use this NRSP platform for updates regarding treatment protocols, and we can arrange stroke training courses for physicians. We can share interesting case studies, and we can use, in the future, we can guide and train our juniors with stroke and neurointervention simulator courses. Thank you.